Good evening, everyone. Good evening, everyone. Can anyone hear me? Okay, thank you, Lois. Good evening, everyone. Welcome to this session on this teaching session on the pathway to pediatric surgery training in the UK. Mr. Gbenga will be taking us through this lecture today, and then I'll be handing over to him shortly. Thank you, Bidemi. Thank you, everyone, for joining. We should be starting in a minute or two. And just before we start, I would like to say if you have any comments or questions, just so we don't interrupt the flow of the teach, just type it into the chat box, and then we'll take all questions and comments at the end of the session. Thank you very much. Mr. Gbenga, please, you can take over now. And thank you so much for agreeing to do this. Thank you so much. Hi, good evening.
Good evening. How are you doing?
I'm fine, thank you.
Great. You can hear me okay, yeah?
Yes, we can. Okay, loud and clear.
Brilliant. I'm a bit new to Middle. If I'm sharing my screen, what shall I use? Yeah, I can see it present now.
Yes, I think it gives you an option to share your slides. Yes. And it gives you an option to share your slides, I
Okay.
think.
Okay. Share slide.
So I think there's an option screen, and after that, it gives you the option to share your slides.
Yeah, I should go with share slides, yeah? Green. Is that correct?
So it says share screen first. I think after sharing your screen, then you can share your slides.
First.
Yes.
Gotcha. Fine. Let me know when you want me to. I think I've done a bit of practice.
Okay. All right, please go ahead. You can start whenever you're ready, please.
Oh, come in. Uh, can you guys see the screen then?
Not yet. Okay,
Yeah.
yes, we can now. Yes.
So you can see pediatric surgery pathway.
Yes, we can see Yes, we can see it.
Okay. Bear me one second. Hey, hello, everybody, and thank you for having me on this platform. It's such a privilege to share some thoughts with you guys. I hope our time together will be productive.
We hope so too. Thank you again for doing this.
So I'm just going to run through
Okay.
about pathway to pediatric surgery in the UK. Similar journey as most a few years ago. Hearing or you're not seeing my slides, okay?
Yes, and we can hear you clearly. At least I can.
Great. Awesome. So a little bit about me. Finished med Lorry and house job OAU, served in Katsina. I've always known I wanted to do surgery. And so I started to residence in Lorry. I did 14 months, and I, like many people would understand, I just got tired. And I wanted to explore training abroad. So I was so desperate. I just gathered all the money. I decided October 2013, and I decided that by January 2014 I must be out of this country, because I was due to write my part one April. So in my mind, once I write my part one, I'm not I'm not staying back. I'm not leaving anymore. So the quickest way for me then is doing a master's. So signed up for masters in cancer storage. I didn't want to do public health. Everybody was doing public health, and left. So 2014 January, I moved to the UK. Started with masters, and I'll talk about that as an option later on. After the masters, I started to root my plabs during master. I started working initially just as a non-training job. In fact, I started with general medicine rather than surgery. I'll explain why later on. So I got into core surgical training, which is an equivalent of junior residency. I was quite lucky. It was quite difficult at about that time. But when I came in 2014, I did not know any single person that was in training in the. I'm not saying surgery training. I mean training. I'm sure they were, but I just didn't know anybody. But thankfully, thank God, I crossed in. So started surgery training in the UK, in Sheffield Children's Hospital. I'd always known PI surgery, so I did a year of pediatric surgery as a junior resident, and then 2 more rotations as a core surgery in my core surgical training. As I will explain later, you would have to apply for higher surgical training. Basically, you lose your job after your core surgical training. So I didn't get it the first time, so I had to apply for. I did a non-training surgical job, pediatric surgery job, and then I got higher surgical training. I'm currently SD7, meaning that I've got 1 more year in my training to become a consultant. And I work at Children's Hospital, Evelina Children's Hospital in London. So yeah, it's been a journey. So summarized, I'm talking about 8 years journey so far. Why ped surgery? I do like pediatric surgery because I think the results are fantastic. I picked interest in it right from when I was in Nigeria. I did general surgery, and people died from different reasons. The supportive care was terrible. So we did fantastic surgery, and we come on the ward round, and Mr. XYZ is dead. Why? We don't know. Great. We just carry on. But I didn't see that. I saw it differently in pediatric surgery. The results were great. If the child is sick, fix what's wrong in it with them, and then they're ready to go. So even tumors, cancers are treatable. most of our solid tumors are manageable and life expectancy is still as good. So that was my first interest in it. And we are the only true general surgery. Nowadays, things have been quite divided. You get trained, I will show you my next slide, in quite a very broad specialties. I do like to be a little bit in the chest, a little bit in the abdomen, a little bit in the groin, urology, and all that. Plus, you treat from preterms, actually -0 to 18. So 18 is an adult, and 0. So you see quite a range of cases. So one is a broad range of region you're treating. You're treating quite a broad range of cases as well. And lastly, you get a bit of life. General surgery is mass easy. So I wanted to be a general surgeon, but I just want to sleep in my house and have a bit of a lifestyle. Pediatric surgery affords me that. If you think about it, I 0 to 8, 17 that need surgery. Yeah, the general surgeons or other surgeons will manage 18 to 19 something or whatever. So population wise, the amount of children you have in a given population is about 1/5 of the whole population, and then the amount of sick children even smaller. So it's not too busy. It's busy enough to get you going as a surgeon, but it's not too busy to mean you just round the clock in the hospital. Is everybody still hearing me? Can you still see my slides?
Yes, we can. We can see your slides and we can hear you clearly.
Brilliant. Thank you. So, and this is the scope of practice of a pediatric surgeon in the UK. This is one of the things that interests me in the UK as well as in Nigeria and in other developed countries. I know we do a bit of head and neck. We do thyroglosal cysts, lumps. We do lymph node biopsies. You're trained in thoracics, so I do lung resections, pleural disease, esophageal surgery. We don't do cardiac. We do thoracic. Everything in the abdomen is ours. Bowel, solid organ, hepatobiliary, tumors, whatever you can think about it. You're trained in urology as well. So kidneys, ureters, postpardias. It's also part of our scope of practice. We are the pediatric gynecologists as well. So, ovarian cysts, we manage ovarian torsion. We don't do obstetrics. So, is a 15-year-old getting and has such complications of their pregnancy? It's not in the scope. And then general surgery, lump bumps, skin, and then vascular. So we deal with big vessels. So vascular access lines is all in the scope of. So this is one of the I do like to be broad. I do like to be trained in quite a wide range of specialties. Right, and moving into the UK specifically, I imagine a lot of you are either just been in the UK or planning to get into UK, or either so early stages of your career, I imagine. The good thing about the UK practice and pathway and training is that it is very recognized in the world. The only place you can't work as a UK trained doctor or surgeon that is certified is America. And sorry, the only place you can work without writing an exam is in America, and vice versa. Americans too can't work here without writing an exam. I guess it's just a beef between Americans and Britons. But everywhere else, you can just walk in, apply for a job, and say, I trained as a pediatric surgeon in the UK, and you can get into theatre next day. So it is quite recognized worldwide, and it's robust. I mean, the training is, I did a bit of residence in Nigeria, and you just fun things, how do you suture? You just start. How do you learn to do laparoscopy? You just start. And things that things that don't come into your fall into your path, you don't know them. But it is quite structured. Everything is broken down to curriculum and in stages, one after the other. There is a lab where you are taught basic things like suturing, a lab where you're taught in how does laparoscopy work, and it is quite robust. They really, you're rounded. You're not just somebody that can cut and sew. You're somebody quite grounded in research and grounded in organization and stuff. I put it accessible in the sense that it's fair. That's the right word I want to use compared to other systems. A lot of my colleagues that in Canada, up until the last year or so, have just not been able to get into anything. Even family medicine, that is, people are struggling because they've just blocked it out. These are for Canadians, these are for non-Canadians. But you would do some work, but it's accessible. You can get it. It is fair. I saw a paper recently about surgical residents in America and how they've been bullied and how they've been harassed, and they can't say much about it. Of course, there is some, but there are a lot of safeguarding mechanisms to protect you. Racism in America is sometimes, in some places, can be black and white, like really full on. I'm not saying there is no racism in UK, but at least it's a bit subtle. And there are sort of mechanisms that protect you. So that's what I mean by accessible. You can get to anything you want to do. Last thing I put there is training and non-training. The fact that you can work in UK as a non-training doctor, so you can come in and start working as a surgeon or whatever without having a training post. Unlike in America, where every doctor is either a consultant or a resident, so it means you have to match. And I think that creates a transition, for us. Also creates multiple entry levels. Anybody that is going to America, with no matter how many years you've had an experience you've got, if you get in from year one intern, even if you've been a consultant in somewhere for years, but some of those experiences can be accounted for in the UK pathway, and you can even enter and at a higher level in some places. Well, the cons about it is a long system. From day one that you graduate to when you become a consultant, all being equal, if you don't miss any step, if you get everything on time, it's a 10-year training from FY1 to become a consultant, to become a surgeon. There are some other specialties that are less, but it's not so it's shorter in other countries. There's a lot of paperwork, as I will talk about, and it's not run through. What do I mean by that? At different gaps, you have to apply and reapply for the job. So you finish internship, apply for residency, junior residency, finish core surgery training, which is also junior residency. You have to apply for higher specialist training, and those jumps could take you some time to get to crossover. So that's what I mean by that. Are we still all together? Everybody's still following me? Because all I can see is only my screen. So I just want to be sure you guys are you with me?
I think I'll just leave my video on.
Sorry?
Yeah. Well, we can hear you clearly.
Good, great. I just want to know. That's fine. I just want to give you an idea of the surgical training structure in the UK. Many of you might have come across this. And you finish medical training, medical school, and you go into what they call foundation, which is quite broad. It is the equivalent of our internship. So you still do medicine, pediatric it now. So if you want to do surgery, you don't have to, they can streamline your house job sort of rotation. So it's 2 years so that you what we call core training. It's the equivalent of our junior. So this is also what they call SHO. So it's a national application. You apply. It's 2 years. Now, if you have an idea of what you want to do, if, for example, you want to do pediatric surgery, they will make sure they will try and get you a year's worth of training and then do 2 more rotations. So I did 1 year of pediatric surgery, 6 months adult general surgery, and 6 months of adult urology. Now, so we don't do 2 more, unlike in Nigeria where you do everything for 3 months. And then that 2 years, you must 2 years pass your MRCS, which is the equivalent of now a higher specialty training, which you now start bearing the name or ST3, and this is one. And after that, within you CS, which is equivalent to part 2, and then after that, you get a certificate of completion of training and then you become a consultant. So basically, this is how it works. There is an alternative pathway where you can rather than go through formal, you can go through and be gathering your competence a little bit. What's spectacular about pediatric surgery? There are only 20 centers in the whole of UK, I mean England, Scotland, Wales, and Northern Ireland that do pediatric surgery. So it's a very regionalized system. For example, I know a lot of you are Nigerians. It's not every state, for example, that will have a pediatric surgery center. So, for example, Southwest might only be covered by a center in Ibadan and a center in Lagos, and every other towns will have to transport. Now, the general surgeons there will do a little bit, but anything that needs more specialist center would transport. So, it is a small community. There are only about 250 pediatric surgeons in the whole of the UK. So it's a small niche, and the map there shows you the distribution of the centers. So I work in London centers. There are 7 centers. So actually, under 1/4 or 1/5 of all the pediatric surgery work. What does that mean? What that means is that they need less people. It's not even unlike in general surgery, adult general surgery, or orthopedics, where every general needs one. Every general surgery needs a pediatric surgeon, so it's largely tertiary centers. And there is, to enter into ST3, that's the highest training. Sometimes one competition. Basically, there are 60 applicants, 6 jobs. It's a national application, and everybody will be ranked. Or 60 applicants, only 10 jobs. Thereabout. When I got in, there were only 10 jobs. So it means the application is a bit stiffer. To put it in context, nationally there are 130 jobs for orthopedics and about 120 jobs for general surgery. And we're talking about just 6 or 7 for pediatric surgery. So that's where the challenge comes in. But it is doable. Anything is possible. We'll talk about that. The consultants, so each of these centers, we call it consultant. So this is Scotland and covers one consortium. Scotland has own Glasgow, and so everybody, for example, somebody in Inverness or Aberdeen will have to be referred there if they need specialist pediatric surgery service. As a trainee, you have to. Let me. If can you all see? Are you able to see my cursor moving?
Yes, we can. Yes.
Brilliant. I can. I'm only seeing my screen. The chats actually. Maybe I can see if I can hide it. Uh, Carry on. I'm not sure my um details is that advanced. Okay, so I'm back to my screen. Ooh, and my down. Sorry. Okay. So I was talking about consortium. For example, this is one region. So you can start your London, South, and is Oxford. And although it looks small, but in reality, you have to move. Saying somebody does a year in Lagos and then does another year in in probably I would say more realistically Ilorin, and then back to Abuja, sort of such geographical distributions. So it's quite a wide region, and you might have to move either you commute to families. Right. I think this is what most of you guys are in. How do you get into it? What's your pathway? I just want to start by emphasizing that nothing is impossible. Um, when I came into the country 8 years ago, when you tell somebody I want to do surgery, they say forget it. It's not for foreigners. That's untrue. That's a lie, and the lies have been broken down. It will mean to take some work. You're not just going to walk in and then somebody knocks and you give you a training number. But it is possible, and that's the first thing. And if you don't get anything from this talk, just take that in. If I want to do it, it's possible, no matter the specialty. Surgery is one of the most competitive specialties. Surgery is the most competitive specialty to get to, and in surgery, pediatric surgery ranks second. So neurosurgery is the most competitive, and pediatric surgery next. And cardiothoracic is about as power as pediatric surgery, but it's possible. You just need to strategize to know what are the advantages available. What are the things that are resources available? Now there is information. Everybody knows or has a friend that is abroad that is in UK that is in training. So it is much easier now, unlike it was years ago when, like I said, when I came in, I did not know anybody, not even doing GP. Everybody I knew was just working in a non-training job, and unfortunately, there was this self-fulfilling prophecy and say, oh, you can't get in. And people were not even trying anymore. But now there is information. In fact, some of them have more information than I do because I'm not trying to get in UK, and so I'm not really researching other things. And the second big advantage visa, before they used to call it a two, the work permit visa. Before I came in, or up to 3 years ago, before they give any non-UK doctor a training post, they must have made sure that there is no qualified UK or EU person that can fill that post. So basically, we only get leftovers. So let me put it in context. For junior residency core training application in surgery, there are about 600 jobs. I mean, the whole of surgery, all specialties, and there are about 800 applicants. UK trained applicants. So for people is more than the number of jobs. So there is no chance. On the converse, for example, in general medicine, if you want to do internal medicine, there are about 1,200 jobs and there are 1,000 applicants. So there's 200 slots that foreigners can compete with for. But in surgery, it was almost, there's nothing left. But this is changed. Now there's this new health and care visa Tier 2 work permit. It means you can apply just like any UK trained doctor for a training plan, you'll be considered. And I think that's the biggest news. There's no more wait until leftovers, until there is a rare chance of them. So I think that is an encouragement to you and to you guys, and that makes it more accessible. Once you come into as any doctor, so there's no limitation. Like I said, it needs hard work. How do you get in? The first thing is to get a GMC registration, and there are a few ways to do it. PLAB, probably the most commonest route. I'm sure many of you are aware of the PLAB exams and how to get to it. But the other way is, especially for those that have had a few years of experience in surgery, and you're sure you want to do surgery, is MRCS. Just write the MRCS exam, and you would get a GMC registration to practice surgery. For PLAB, you can practice anything. You can do surgery, medicine, peds, GP, but MRCS is a streamlined sort of registration. And for those of you that are quite convinced that you want to do surgery, you can do for that. But I think it will make sense if you're in residency, or some of you that has finished training. And I would, because if you want to do surgery, you would need to write that PLAB MRCS anyways. So to progress into ST3, you must write the MRCS. You must have passed the MRCS. So it might not be a bad idea to just write it and use that to get your registration, and then use that to get a job. MTI is another way. Basically, it's medical training. So a hospital or a college would sponsor your visa, your registration from the GMC. For Nigeria, you must have a West Africa College of Surgeons, so part 2, before they can sponsor you. I would not, for anybody interested in pediatric surgery, I would not really around that must come through MTI into pediatric surgery. There might have been, but I've seen more in with orthopedics and general surgery, larger specialties. So because why? To get them, so if you have a F works, for example, the hospital to agree to employ you, and with that you go to GMC and say, this hospital wants to take me, give me registration. And unfortunately, when you meet hospitals, they'll say, no, you get a registration first, then we employ you. So it's quite tricky. It's not it works well for pediatricians and the physicians in medicine, psychiatry, because there is a lot of shortage. They need a lot more people there. So hospitals are quite keen. But in surgery, it's a bit tricky. Once you get your registration, I think the next thing is to get a job and get into the country. That's the benefit of the UK pathway. You can just apply from your room and get interviewed and get a job. So I would strongly recommend trying to get into an NHS job. And if you want to do pediatric surgery, get any surgical job, general surgery, pediatric surgery, just be broad. You can't get any surgery job and get into the country. It's until you get into the country that something starts counting for you. So I wouldn't be so fussed about, oh, it has to be ped surgery, just get any surgical job. And once you have your registration, just go on to NHS jobs and be throwing in applications and apply. Um, so I think getting to the country first gets you a better chance. It's uh, unlike GP from general practice, you can be in your room from Nigeria and apply and get into general practice training, because we're talking about 3,000 applications, slots per year. But for core training or for surgery, higher specialty training is a bit tricky. The numbers are not great, and you will need some things that you can only get in the UK by working in UK to score high and rank high to get a job. So my advice would be just get into a job, get a job, get into the country. Um, any job, pediatrics, any whatever would this thing called NES, which is like the private sector. Quite keen, they sponsor you quite well. You get in quickly. That's an option if you're struggling to get an NHS job. Now, get into the country. I think it's old school to spend a lot of money coming to do masters. So, I went through way 8 years ago because the information available now wasn't there, but it wasn't there back then. It's a lot of money, 10 to 15,000 pounds, plus you're going to spend a year working in odd jobs, because it's until you start working as a doctor before you get any pay that's reasonable. I came to the country and I had to pick up odd jobs just to survive. So it's a year of I would not recommend it. If you that will give you scholarship, full scholarship, wow, of course, take it. Come in, do it, get in the country, use it to, while you're there, write your plabs. But I would not. I've seen the people who just, a lot of people just wanting to get into the country and signing up for a master's. I think it's painful. You can, if you get your registration, you can walk into a job that would support you and your family comfortably. Year of pain. Now, once you got your registration, you got into the country. How do you get into the training? As a CT1, which is junior, it's a national application that opens up in November. Interviews are in February, and the job starts in August. So it's like a national session going on. Some of you that have had in Nigeria in surgery have more than 18 months experience after house job if you want to start getting to core training. So if you've had more than 18 months experience in any surgery, general, orthopedics, you would not be eligible. And that's why when I finished my master's, if you remember, my first job was as SHO in general medicine, because I'd done 4 months of surgical training in Nigeria, and I didn't want to miss that chance. So I did general medicine until I got a core surgical training job. Now, for those of you that have had a bit more experience, if you have more than or if you've had more in another country, Nigeria, for example, I would say at least 2 years of experience of postgraduate surgical training. I don't mean working in private practice of surgery. I mean postgraduate surgical training. I mean residency. The MRCS, you can enter here at SC3 level, which I think is quite. Also, if you did core surgery training, maybe the application is quite difficult. You can do 2 years of surgical non-training job and write your MRCS, get some consultants, some competence, and you apply for ST3. Yeah, and so actually that it's a bit commoner where people just come straight into ST3 more commonly. And that's how you get trained. Now, there is something called an alternative pathway, which is called Caesar pathway. Basically, you just do non-training jobs and you gather your paperwork and you apply the completion of training. Tricky. There are some things that they just sign up for you without even asking if you're in a formal training program. But you have to do all those things one after the other, one after the other. Now, I have a couple of people that have done it in pediatric surgery only recently. And orthopedics, I mean, the largest specialties, they have that pathway. But the attrition rate, if 100 people set out to want to go through the pathway, only about 25%, 25% will be successful to get there. On the converse, if 100 people become a surgeon, 90% of them will get there. So a lot of them will either just give up on, oh yeah, the specialty, or great. Basically, you are like a registrar, not a consultant. It can be quite frustrating lifestyle. So yeah, that way I wouldn't recommend it. But if that's where you are, I would say go for it. Information is going to be available. There are more people going through that as well. So the reason why it's difficult for people to progress might be because there's lack of information. And now you probably will see more people progress quicker. What can you start doing now? So for those of you still in Nigeria, like I said earlier, this is a very paperwork-based system. They believe is for be a surgeon is not just only know how to do laparotomies and cotton. So you need to be grounded in academic, to be grounded in leadership, you need to be grounded in research, and so you are scored on those things. The question is based on how many points you have in this. So take a snapshot of this, and these are things you can start doing. Can you get an extra degree online, MSc in something? I know a few colleagues that have done that. While you're there, if you think it's going to take you a while, I came in to do a master's, and my master's called me this point. But honestly, I would not devote 1 year of your life plus £15,000 just to get an extra degree. 2 or 3 points. You can get points as well. So you can look into that. MLCS, if you can start into writing your MLCS if you've passed your PLAB, or if you want to go the alternative pathway courses. There are things like basic surgical skills course. I know that is going on in Nigeria. Now, there are just a few courses, to be honest, that they recognize. So it's not just I went for an update course and they taught us some. I don't think that counts that much. But if you read around it, particularly basic surgical skills course, advanced life support, those things count. Pediatric life support courses, if you can get onto that. Can you write a paper? Yes, you can. I wrote my first case report as a year one surgical resident in Ilorin, Nigeria. We saw a case. My consultant said it's quite nice, and I wrote the summary paper. So you can publish a paper, case reports. You can participate in a research going on and be an author on that paper. You can write a review. I did orthopedic surgery, and they were really dazing us on classifications in orthopedics, and I went to all the classifications, and I summarized, like, oh, this looks good. Wrote a paper on it and got it published. I sat down in my room one day, signs of free peritoneum gastrointestinal perforation. And I just started reading around science, and I found a few signs. I was like, oh, it's good. Put it all together, wrote it, and I published in a paper. So you can publish even without working in a research center. Those are points. All of these things are points, and that's what will be needed to get you across to get you across that bridge. Presentation. I also, as a junior resident in Nigeria, I presented a research work we did at an ENT conference in Ilorin. Now, I didn't actually know that I was coming to UK, to be honest. I was just trying to get involved and, do all the groundwork for my bosses. But these things turned into useful things. I counted all of those things into my points, and that helped me. So, what teaching? Now, I know many of you would pull medical students aside, as a house officer, as a resident, and start teaching, or many of you have taught some other things, but it has to be one, it has to have evidence for them. There has to be evidence for them. This is a rough way of how they grade is. So you get 3 points for teaching medical education. I wouldn't recommend spending massive amount of 3 points for that. If you're on a faculty, on a course, you get 2 points. You have regular involvement in teaching, you score 1. No involvement, score 0 points. So I think push for teaching. And how do you get evidence? Anywhere they ask you to come and in a presentation, print out some feedback papers and give them, say, give me feedback, and that's what you can put together as evidence. If they ask you to do a presentation, ask, can you give me a certificate that I can show somewhere that I deliver this presentation and this teaching. If there's a course you can set up, if there's when I was as a core surgical training, junior surgical training, I just saw some medical students coming from ward round, so I gathered them together and I created a basic surgical skills course. I spoke with some other departments that had some stuff. So on paper, on plastic, I was teaching them how to suture, and it was my course. I started the course, and I got evidence for that. Whatever it is, try and get paper for it, because it's all evidence based. Prizes, award, having, they say you are the most outstanding copper doctor in the village. Just say, can you write me something for that? Give me a certificate for that. I got an award as when I was serving in Katsina. There's one village called Kusada. I did a project and I got an award for that. I said, no, give me a certificate. Don't just say, because everything would be presented as paper. If you scored, if you won a prize, or if you're a medical student, if you can get a prize, don't just collect the money. Ask your university to give you a certificate. The best student in pharmacology, best student in obstetric, get a paper for it. House job, they said you are the best intern in the department. Ask them, please give me a file. Of those are all points. And even non-medical things, if you do any extracurricular things and you get an award for it, get paper for it. It is all paper-based work, and you can start putting your paperwork together right now, knowing that this will be required. There's something called audits, which I think might be a bit tricky for some. I don't know, maybe not, but we can talk about that. And what can you start doing now? Get as much surgical exposure as you can. Surgery is surgery. Peritonitis is peritonitis. And it will add up, not only to add your practice, and start getting skills up to get as much exposure. If you're doing a job, make sure you get into this, make sure you assist in cases, make sure you practice suturing things, get involved. If you work in a private hospital setting, be the first person to want to assist in surgery. If you can, get a job that would, be more surgically involved. For example, if you're working as a medical officer and you can choose whether you work in medicine, surgery, choose surgery, get as much surgical exposure, and make sure you keep a log of every procedure you've done, even if it's incision and drainage. And you honestly don't have to have any special thing, just an Excel sheet, date, uh, hospital number of the patient. Don't put the name of the patient, hospital number of the patient, and diagnosis, procedure. Did you assist or you performed it? And make a little comment. Just put all that in an Excel sheet and save it. That can be your logbook. And when you finish that job, get somebody, the clinical director or head of department, to sign on it and say you have done these procedures. Those can be added to your package for I did my house job. I assisted a few surgeries. I even led on some. I wasn't this survey, so I didn't have a logbook. But thankfully, I did surgical. I started a residency where we have books, so I use some of those things. But some of you might not. So start, and there are some online softwares that are quite cheap. If you just Google surgical logbooks, and you can use that as well. Yeah, get as much exposure, document all those things. Get help. If you are now, when you're applying for a job, get help with your application packaging and interview prep. Don't just go on to NHS job and fill it in. And let me tell you this, I've sat with people that are training people's application for jobs. I mean, by reading through what you've written, that's the point where it is screened up to 60-70% of people. And the reason why some people are not getting interviews is because they want you to, if you can, think like a doctor that is working here. And it's quite difficult if you're not in the country. So speak to somebody. I'm sure you know somebody somewhere, and say, look at my application, make advice. Sometimes just terminologies. For example, you write internship, OAU, service, National Youth Corp in Jalingo or Taraba, but just changing the names to say internship, call it FY1, because that's what you understand. Service here, call it FY2. Putting it in the context they understand helps. An interview prep. If you get an invitation for interview, don't go to that interview without speaking to somebody that is working in the UK doing surgery, if it's a surgical job or whatever specialty that is related. If it's a pediatric surgery, it doesn't have to be a pediatric surgery person, but somebody that gives you an idea of how to talk. Many people have lost opportunities because of that. And that's what you can start doing. Now, final thoughts. I would say try and get as early as you can. The older, not let me use the word older, the more experience you have in Nigeria, having to come back to start again, the more difficult it is. A lot of the people that I've met that have not been able to follow to achieve their dream of becoming a pediatric surgeon is even though they fully trained back home, is because they've spent 7 or 8 years training, then coming here, you're looking at another 8 9 years ahead. It can be daunting. So many of them just say, man, I forget it. If you are an early career doctor and you think, I want to go to UK to train, I would say do it as soon as you can. Really. I don't think there's any benefit finishing your residencies or training in Nigeria and then coming here. Some people say, I want to pass part one. I don't think it adds much, to be honest. My getting as early as you can. And lastly, keep you read everything around it. Do you know you can have more information than I have now? Everything is online. That is the benefit of this system. Everything is online and you can just be googling. In fact, I'll be wary of some of the information you get from people, especially some of us that are a little bit more advanced in a, I've worked 8 years ago or so. So some of the information I have now might be outdated. So there might be newer ways of getting in. There might be an opportunity. Spend don't let a day pass without, the same way most of us would scroll Facebook every day. Don't let a day pass without you googling something about pediatric surgery in the UK, if that's what you want to do. And you see opportunities, you see scholarships. I'm finishing my training currently, and I want to pick up a fellowship in Canada, and I'm now in that hoop in that stage, and I'm scrolling every day, reading about it, knowing what do I need to do, what opportunities are available to me. You can get everything online. You don't have to speak to anybody particularly. I wish you all the best. This is my email. Feel free to write it down and contact me. To respond to as many as I can to help with advice and whatever things that may be necessary. Great. That's all I've got, guys. Any questions? Sorry, I lost track of the track. I've not been following the charts. Okay,
Thank you
that's
so
all
much,
I've got.
sir. Yes, thank you so much. So if anyone has any comments or any questions, please type it in the chat box so we can do that in the next 2 to 3 minutes before
Should I
rounding up.
stop sharing?
I guess you can, sir. So we'll just wait a few minutes to see if anyone has any questions or comments. Thank you so much for being guys. It has been quite insightful. For me, from the lecture, you were just able to put into words. I mean, the reasons why I've always been drawn to pediatric surgery, and this will help all to start working on those on the things we need to make the journey easier, the journey into training easier. So thank you so much, and thank you for the email address also. This is expecting maybe from me soon. So we're still waiting for those comments and questions before we call it today. Okay, I think we have our first question.